Okay. Good evening, everyone. We're so glad that you could join us online. It's a very strange time of year, 2020, but we're glad patients and fellow colleagues and friends and family. We hope that you'll enjoy this evening. We have presentations, and at the end, we'll actually have a Q&A. So online, just simply type your questions in, and we'll try to get to as many as we can. We hope you enjoyed the music. We'll have that a little bit later as well. Mayo Clinic is a stroke center, and we'll talk a little bit more about that. Lots of trials going on, and so I know you'll enjoy the speakers. First up, we're actually going to do something a little different. We're going to go to our nurse, who's in charge of our stroke patients, named Lisa Mooney, and she's going to be live on the floor on 5 South and also 4 South, who take primarily care of our neurosurgical and neurology patients. And she's going to ask some questions of nurses that are working right this very minute, taking care of people like you that have been patients of ours. So I'll turn it over to Lisa. If she's ready. Yeah, let's see.
Lisa, this is media support. You may just need to remember to unmute yourself on your device.
A lot of emergencies going on at the moment. Bear with
Hi,
us.
Grace.
Hi, Lisa.
Can you hear us all right?
Yes,
Good
ma'am. We
evening.
can hear you.
Great. I have Lynette Faustino, one of our team leaders and nurses on 5 South. And also, I'm going to very slowly go over. I have Marby, and she is also one of our excellent nurses on 5 South, the neuroscience unit.
And I relieve TL now.
Yeah, yes. So, thank you guys for being willing to participate. Do you want to stand over there, Marvin?
Yeah.
Okay, wonderful. That way I can capture you both. So thank you, Grace, for having us, and thank you guys for being willing to participate. So may I ask how long you've been with Mayo Clinic?
I've been with Mayo for a little bit over 2 years now. 11 months.
Okay, wonderful. So that's a while and not so long. So I hope you're enjoying it. So how, with you guys working on the floor with neuroscience patients, have you faced challenges in your daily work caring for neuro patients with the pandemic?
I feel like we're still affected by it, but not as much. I feel like the other floors when COVID started, because I think it's just the part when they have to do all those routine. They have to, if patients going to surgery, and they have to continually do the COVID testing and do COVID testing for every patient. So I think that's something new.
I think the other challenge also is because we're not allowing visitors, especially in the beginning, and when we have the second wave or third wave. Of course, you go into surgery or post-surgery, everyone wants to be with their loved one. Every patient wants their loved one to be updated, and they're not physically here. So that could be challenging for both patients and the staff.
Okay, I bet that is very hard. So what are you guys doing, to help cope with the pandemic and care of patients?
I think first is with the visitor, of course, thank God for technology. We have offered FaceTime. So we utilize that a lot, especially when it was strictly no visitors at all. The other part that the hospital did is the call center. So when we didn't have the call center was able to update family members on pretty much every shift, I would say, or when needed. As far as patient care, I think, we were just more vigilant in making sure that, that they're understanding of, why they're here or what the process is. And I just speaking from experience, I know they had a lot of concerns with COVID, so a lot of re-education about how the pandemic would affect their care, you know, or how everything is gonna affect them when they go home or like post-op or while they're here. And a lot of up in the questions with the pandemic. Or like in the beginning, I think it was a lot harder, but now that we know more, it's not as. I think there are less questions now.
Okay. All right. And so what about neuro? Do you love neuro? I mean, obviously, if you're working on a neuroscience floor, when you have so many other areas you could work in.
Yeah, I think you gotta love it for you to stay
They
in this
stay.
floor.
Yeah.
We have floats and they don't like it staying in. I think you just have to find your own
It's like
area.
finding your niche.
Yeah.
Okay. And so if you could offer any advice for any other frontline workers working both in neuro and during the pandemic, what advice would you give?
I think, advice. I think we're just five staff got lucky. I mean, I'm new, so I've only been here 11 months. So I'm just speaking from my experience. The teamwork really helped because I mean, patients and everyone involved were of course apprehensive with the pandemic. Who wouldn't be? Especially if you're coming in and you're coming home, you're going home, you have little kids at home, and then you have patients who are anxious, but I feel like the teamwork helped with that. You kind of help bounce back ideas with your coworkers who are also in the same, apprehension that you're feeling, and they're dealing with the same patients. As far as advice, I feel like Marvy said, you're gonna love it. Like that's how nursing is. I feel like if your passion is really there, you can go. I mean, nobody wants to go through another pandemic,
Right.
but if you're compassionate and you're in it just to serve your patients most and foremost, first and foremost. I'm not saying it's gonna be easy, but it's not a drag going to work because you love what you do.
Very good. Well, thank you guys for your time. Grace, do you have any questions for our two fabulous nurses?
I'm just so thankful to them for taking such incredible care of our patients, and just very thankful. And I'm sure some of our patients out there have already met them.
Yes. Well, okay. Well, I will let them get back to work. Thank you guys
Thank you.
for stopping. I know you're busy. And Grace, I will now travel downstairs.
Okay.
And
We are going to have a break from you, and now we're going to be calling in to Jessica Borge. She is an IR tech here at Mayo Clinic. She works extensively with our patients in acute settings. We are very honored to have her from home, and I'll turn it over to Jessica. Hi, Jessica.
Hey everybody, I just wanted to introduce myself. I'm Jessica. I'm one of the IR techs. So I get to work alongside Dr. Miller and Dr. Talk. I get to help perform these procedures. And I was just gonna share encouragement to you guys because I just wanted to let you know here at Mayo, you're in the best hands. We continually do everything we can to be the best and put your needs first. And we truly get fulfillment from your recuperating from your aneurysms and strokes. If we get a stroke patient and it's just truly encouraging when we get you in, bring you onto our table, everything is super fast and like crazy trying to get this clot out of your brain so that we can help you get better as fast as possible. And just the whole turnover of that. And then at the end of the procedure, we get to see you talking to us and moving your hands and feet, things you weren't able to do when you came into the room, even just 30 minutes after coming in. It's just extremely encouraging to see that. And so I just wanted to share my position, what I do, and how much I love my job and how much I love taking care of you guys and seeing the great outcomes. And I love getting your cards and stuff and hearing your stories. So if anybody hasn't done that before, just letting us know like how we have impacted you guys is just really encouraging.
Awesome. Thank you so much for sharing. How long have you been at Mayo?
I've been a tech at Mayo for about 5 years now.
You've seen a lot.
Yeah, we've seen a lot. We've done a lot to improve our process as well. We've got a specialized team. We call us the neuro ninjas. So we dedicate time to do specific training. Like we do simulations to create like a faster work pace, a more efficient, flow. We kind of do like a lot of extra training so we can, give the patients the best care.
Awesome.
And decrease our time so that, everyone probably has heard that brain is time. And so like when a stroke happens or, taking care of a patient with the aneurysm, these things, like we need to have that extra training. And so doing the extra stuff that the neuro ninjas have done has definitely decreased our stroke times, which gives us a better patient outcome. So.
Absolutely. Anything else you want to share?
I think I'm good.
Great. Okay. Thank you for sharing. I'm going to turn it over. Let's see if Lisa's ready. I think she was going to talk to a couple other nurses on 4 South, and then we'll start with other speakers. Are you there, Lisa?
We are almost ready, Grace.
Awesome. It's very red. Very red. Yeah, so please come with your questions. We're just so thankful that you're here with us tonight. Patients are everything, of course, to us, and sometimes we get caught in the technical side of so many things, but it's taking care of patients and making them feel better and having their patients and their families be comfortable. That's our main goal, for sure. Also, I want to point out, we're going to try this again. We're sort of experimenting a lot with this now, but we're going to try this again in May. Hopefully a lot of it will be live as well. We usually try to get together at least once a year and have a social event with food and drinks and things like that, and just for a way for patients and their families to have a lot of support and similar format. How are you doing, Lisa?
We're doing well. How are you?
Great. I know it's extremely busy and it's right at shift change. So we're so thankful to hear from another person.
So I have Morgan here with me, and she is one of the nurses on the critical care unit. And I don't know if she can hear you. I was having a hard time hearing you. I had my earbuds in. So Morgan, how long have you been with Mayo?
5 years, just a couple months ago.
Okay. And I guess you like it?
Yes.
Okay,
Great place
wonderful.
to work.
And how long have you been a nurse?
7 years yesterday.
Okay,
So.
well, congratulations. So one of the questions that we're asking a lot of people, given the pandemic, have you encountered a lot of challenges working with neuro patients?
Yeah, I'd say there have definitely been challenges. The flow has constantly been changing, and the policies regarding visitors and everything has been challenging, especially when family members aren't able to be at the bedside to make decisions or provide information. That's been difficult.
Okay, I bet that is hard. And so how are you coping with the pandemic at work and at home?
Okay. It's definitely still a stressful time. I worry about my parents who are older, and family have just been still taking precautions and keeping my very, very small bubble. I think we've got a pretty good team here as far as teamwork and being aware of everyone's safety and taking all the precautions that we can to keep each other safe.
That's good. That's good. And then, so I know someone earlier mentioned it was really difficult, like you mentioned also about families not being here. How are you helping your patients and families get through this hard time?
They've been doing the Zoom conferences with family members, which I've seen has really, really been beneficial. Without so many family members at the bedside, especially when we weren't allowing any visitors, that was really hard. And it kind of hit me the first time that I assisted with one of those Zoom conferences, like how desperate people are just to be able to see their family member, especially when they're not able to communicate for themselves. So I think that's a great resource, and we have a team that you can just call them and coordinate, and they coordinate with the family, so entire families are able to log on for an hour or two and just talk to the family member, talk to the patient, even if they can't communicate back.
Okay, well, that's very good. Zoom has really taken off in
Yes, it
2020.
has.
Has
Yeah.
so as far as like, given that you're a frontline worker, is there any advice that you can give to other nurses or care team members during a pandemic, or how you've made it through this fire? Because I know it's challenging.
Yeah. I mean, definitely just take care of yourself. Be safe, be cautious. I take pretty extreme precautions, just assume that anyone in the community could be infected, and we've got to do the best that we can to be able to take care of our patients and take care of our coworkers.
Okay, yeah. And so what's something that's very rewarding to you as a nurse on the surgical ICU?
I
Put you on the spot there.
I mean, we see all kinds of stuff on our unit. Neuro specifically, it's really neat to see some of the amazing stuff that we do here, and seeing the just progression of patients with some of the procedures, how they can be life changing, or even patients that don't seem like they're doing very well, and then after a couple of weeks of the treatments that we have, just a complete turnaround. Someone that couldn't speak or move, and then a couple of weeks later they're up walking around, and it's just always amazing to see. We're always doing really just very cool things. Great to be a part of.
Yeah, it is great to be a part of. So well, thank you so much for taking this time. I know it's right at shift change and everything. So Grace, is there anything that you guys would like to ask or add?
No, I just think we're so thankful for all the hard work you do. We really appreciate everything that you do. And I know I've worked with you many late nights, so thank you so much.
Okay, well, thank you. Thank you.
You're welcome.
All right, thank you, Lisa. All right, so we're going to start a few talks. I did forget to actually introduce myself officially. I'm Grace Bryan, and I'm one of the physician assistants here at Mayo, and I've been at Mayo 24 and a half years already, and I've been fortunate to work with a lot of so many incredible physicians, including the ones you'll meet tonight. And the first speaker I'm going to introduce is Dr. Talk. I work with him in neurosurgery, and he does a lot of speaking at our events here for the Aneurysm support group. So I'll turn it over to him.
Thank you so much, Grace. I thank you very much, because without you, this could not happen. And I thank all people behind the scene who made this possible. I thank all our patients for all what they trust us to take care of them and their health, and the most sick patients. So this is our stroke event. We did a merge of this between aneurysm and stroke patients. And what we're trying to do here is basically to live in a COVID time, basically. COVID has changed everything for us, and this is how we're going to live probably for foreseeable future. So thanks again for joining us. For every patient, we are here for you, and that's why we have blood in our circulation, and that's why our heart beat every day. We beat patient care, and Mayo supports us to do this stuff. So can I have my presentation, please? So I hope you're seeing some slides here. When I was thinking about this, I thought about how can I present something to patients that's relevant for them, what's new. So looking at this, this is our webinar, this is how we're doing it, and this is the Mayo system. We are all blessed to work in such a great healthcare facility where, you know, colleagues, people behind the scene take care of the sick patients. This is a video showing how this heart called Mayo doesn't stop in life. If it stops, basically, it's death. But this institution works streamlined 24/7, 365 days, and it's a team. It's a teamwork. When someone is tired, there is another one who takes over. It's a race that never ends. And it's a story that continues going on and on. More glory and better patient's care for the past, for years to come. This is the carbon therapy that this building and technology is going to be coming to Mayo first place in the whole United States. So lots of great news. For the sake of time and out of respect to my colleagues, this is from my high school friend and colleague. He put this picture, which was very inspirational to me. This COVID-19 has jailed every one of us, and life is going to be different for us and our children. I hope we get over this stronger and stronger. I want to show you two cases, basically. One of them is how we do flow reversal technique, and I thank my fellows who prepared those cases for you to see. So this is a case presentation. 87 years old, came, referred to me. He had bilateral endarterectomies many years in the past, and he's 87. He enjoys a good lifestyle. We don't want him to have a stroke, and he is very much scared of stroke. He was found out with carotid disease. So here we look at his CAT scan. This is his carotid, and if we focus right here, this is the calcification in the vessel, and this is how his carotid is getting tight. And this is 18 years after his surgery. So what do you do now? This surgery is going to be very challenging to do it again because there is scar tissue, and we have to go through that. So what we thought was about a different technique. This is a new technique that came about a few years ago where we do surgery below the neck. And I want to go over this video, explain to you how we do this procedure. So this is the patient asleep, and this is the clavicle. And this is where we access the site with the carotid. This is the ultrasound showing the carotid, and that's how we decide how to puncture directly into it or expose it. This is the tiny skin incision. And for people who see blood, please turn your face aside, but this is what we do every day. And here we are opening the tissue to find the carotid artery inside, and we want to get in it. Here we're opening the carotid sheath, and this is the carotid artery. We're very gentle to it, almost no touch technique, and we are identifying the vessel where to get inside. We put a loop to identify the vessel. To retract it a little bit, we put a suture in the vessel wall, and the suture is going to serve to tighten our access when we get inside and to close at the end. Here we're getting venous access into the groin. This is the vein that's compressible when we put pressure on it. We put access into the vein, and here we're going to create a puncture inside the vessel. We're going inside, we put the wire inside the vessel, and this is the open part of the procedure. Now we go to the endovascular part after we get this sheath inside the vessel. And here we go. This is the angiogram showing us how we're picturing this is the stenosis, and this is where the vessel is tight. Here we're establishing flow reversal technique. We connect the carotid artery into a vein in the leg. So the blood, instead of going upward, it's going downward. And here's the wire passing through the stenosis, and we navigate distally. We put a balloon in, we open it up, we crush this plaque against the wall to open a space. We deliver a stent directly from the neck, and we deploy the stent. But during this time, again, because this connection from here down to the femoral vein, the difference in pressure between the carotid and the vein drives the blood backward, downward, so the patients don't have blood flow to their brain and they don't have a stroke. So here is the balloon opening up again, and we open this vessel, and basically we take the sheath out, and we restore the blood flow, and we close the incision here, and all goes well with this patient. Patient goes home next day, and he did great. Next case, I would like to share with you something I have not done for many years, but we're embracing now, is to do awake patient surgery. So we're doing, and I want to share with you this video for an awake surgery for aneurysm clipping. And this is our team who did this. And again, when it comes to this, my boss and my chairman, he does a lot of awake, and he challenged me to do things better, and we took the challenge. And this is the team who helped us to put this case together. Young woman, 46 years old, headaches. She was found with an aneurysm, and this is the picture that we see here. That the black spot here is the aneurysm. This is where it is in location. This is front of the head, back of the head. So this is buried in the midline. And if we look at the other imaging for this aneurysm, including vessel imaging, this patient has a variation. We call it azygos A1, where the vessel, instead of two vessels here, it comes out as single vessel, and right there where the vessel divides and split, this is the aneurysm. So how are we gonna get this done with the patient awake? So this is how deep this thing is inside the head. And these are the pictures on how things look like. And we're gonna move on to the live surgery. And again, tiny amount of blood sometimes. So she was diagnosed with this aneurysm, headaches were severe. We decided to do awake surgery, and here is the video playing. So this is the patient position in surgery. We fixed the head in a Mayfield head holder. We're here opening the skin, and I'll expedite people who don't like see blood, but this is how we take a piece of bone, and then off we go to here. We are here working between the right and left brain, separating the adhesions between the brain and what we call the falx, and it's a structure in the midline, trying to find the vessel. These are sharp dissections. This is what you see is magnified probably 30 or 40 times with the.
All right, stop. Okay. My worst headache.
Being examined. This is the other side. It's very quiet. Here we're injecting numbing medicine because she felt some pain working. So we numb this area. And again, I continue to do microsurgery. And this aneurysm is really stuck to tissue here.
Caroline, find me the letter W, please. 1, 2, 3, or 4. Go. 3. Good. You two, tell me the colors that these words are printed in as fast as you can. Here we go. Ow. Caroline, can you do this for me, hon?
Ow. Green, green, blue, red, green, green.
Good. You can
yellow.
stop. Okay. Go.
Okay.
Good. Relax.
Okay.
So here, the patient is awake. We control the blood supply. So we're shutting down the vessel temporarily so I can dissect this aneurysm from.
It's typical of like your normal headache kind of pain?
Yes, it hurts exactly the same as my headache.
And is the severity of the pain the same as your typical headache?
It's when I have a really bad headache.
All right.
No better way than a patient who's awake. So here, we're almost pushed or pulled out this aneurysm where it was stuck to all tissues, and it has still adhesions to this vein right here. We're going around it, and it's very dangerous maneuver. What you're seeing is
7. Oh.
Hey, Caroline, breathe for me, okay? Breathe for me.
So here we're cutting the last attachment to the aneurysm, and now we're rolling it over, and I'm trying to get underneath it to find the last piece of this aneurysm so we can secure it with a clip. So here is the back wall, and now we're ready to tackle the aneurysm. Few more adhesions to remove, and I still have the blood flow arrested. Here's the clip. I'm applying the clip on the vessel, and here is a second clip for the teeny tiny remnant at the neck, and we apply the clip, and then we remove this clip that was temporarily occluding the blood flow to make the dissection very gentle on this aneurysm. This is a camera angiography. We give the patient cyanine in the cyanine green, and it shows us the flow inside the vessels under the microscope. So here I make sure that the blood vessels.
Like a gas pedal. Good. Relax. W.
3.
Good.
And again, the patient is being examined at the same time on the other side of the table. So you see the silence on this side, and then the action on the other side, and we are a few inches apart from the patient talking and doing the procedure, So this is the final touch-up, and this is the end. The patient did fairly well. This is her imaging after the procedure, and it shows basically the air. So what we see here is dark is the air inside the skull anytime we do surgery, and here are the shining part is the clip applied and no bleeding and so forth. So the patient did very well. Next day, basically, she goes home, and we see her life goes on for her, and she's secure. So that's what I wanted to share with you, 2 things that continue to evolve, and I thought that showing those cases for you, for some people at least, will be appreciated. So thanks again for the opportunity and for Grace again, and we'll go to the next during this. Thank you.
Thank you, Dr. Talk. We're now going to show you actually a video of a patient of ours. So you'll see on your screens. It's a beautiful video in her story, just a brief video that we want to show you now. In 1 second. Maybe. Actually, while we're waiting on that video to come up, I did want to tell you about the amazing work of the piano that we just had, which was Gaetano di Biasi. That's probably mispronouncing that, but he is from Rome. He graduated summa cum laude with honorable mention in the top of his class in Rome. He spent the summer of 2017 and 2018 as a research trainee in Jacksonville, and he's mostly shadowing Dr. Quinones in the OR and doing research with brain tumor stem cell laboratory. So we're honored to have him. So he's multi-talented, to say the least. He is a concert pianist, and so I know you appreciate that aspect of him. And we may be ready for our video. Thank you for your patience.
There's stories behind almost all types of dancing.
For Allison Nielsen, dance is more than just a hobby.
It's emotional.
It's what she's studied for years.
I went to college for it, and I danced over 50 hours a week in high school.
It's what she does for a living.
I teach ballet, tap, contemporary, sometimes hip hop.
And most importantly, it's how she expresses herself.
Whenever there's personal things going on in my life, or if something tragic happens to somebody I know, then I use that as like inspiration for dances that I make. I don't know what I'd be doing if I didn't dance.
6 years ago, just as Allison was receiving a dance scholarship to a college in Jacksonville and making plans to move to Florida, her future in dance was suddenly not so clear. Allison was diagnosed with a rare abnormality of blood vessels called cavernous malformation, or cavernoma. Cavernomas can occur in the brain and cause brain damage as well as seizures.
I had to convince my mom that I'd be okay with going to Florida. And she decided it would be okay because Mayo Clinic is right next to the school that I chose, which was a very happy coincidence. Or stars aligned, I guess.
Allison was referred to Mayo Clinic neurosurgeon Dr. Robbie Talk.
Allison was a delightful patient, young patient who comes with her mom, who's a nurse, extremely anxious about her situation, has the future in front of her and dealing with something like this.
Dr. Talk says Allison's cavernoma is not only large, it's located in an area of the brain that's very important to a dancer.
With Allison, the lesion is located in her motor cortex, which is the area that controls your body movements.
Allison noticed her foot specifically was being impacted when she did certain dance moves. Dr. Talk says surgery to remove the lesion, while complex, was an option. But was it the right option for a young woman on the verge of her career in dance?
With Allison, we know where the lesion is. We know what to do in surgery exactly. At this stage of her life, there's still some unknowns as to the risk of surgery and what is going to be the consequence for her whole future. And that's why we decided to watch.
With the expertise and guidance of Dr. Talk, Allison made a choice.
We individualize her care. We check on her every year. We repeat the imaging. Allison knows if something is different, and she knows where to call and what to call, and we know exactly what to do.
Until that day comes when surgery is needed, Allison dances on.
I don't know when will the last time be. It just makes me appreciate it that much more.
For the Mayo Clinic News Network, I'm Dee Dee Stephen.
All right. We may show another video if we have time later, but that's just one example of the many stories that we have. I would now like to introduce Dr. David Miller, who I've known my entire time at Mayo as well. He works tirelessly for patients. He is here night and day. He's always busy. And we are very honored to have him now as your next speaker.
Thank you for the kind introduction. Pardon me for the technical delay here. Let me put up some slides. Thank you all for who have taken the time to join us tonight. I wanted to just give you a little bit of an introduction for those, many of you are patients and have a personal experience with stroke. Some do not. So I wanted to talk a little bit about stroke in general and a little bit about stroke centers. There we go. Okay. So for those of you who are unfamiliar with stroke and looking to get a little information tonight, I'll start with what is a stroke. A stroke is a sudden alteration of neurologic function caused by a lack of blood flow to the brain. This generally happens in one of two ways: a blocking of a blood vessel, which we call ischemic stroke, and that happens most of the time. Almost 90% of strokes happen in that way. Leakage from a blood vessel, referred to as hemorrhagic stroke, is another mechanism of stroke and can be equally as devastating. So quite frankly, who is at risk for stroke? Well, quite frankly, anyone can have a stroke. Strokes are more common in people who are, as we get older, and in people who have a family history of heart disease and stroke, as well as certain other conditions. But strokes can happen in young people, and as you've seen in some of the testimonies that you've heard earlier today. What are the risk factors for stroke? Well, there are a lot of risk factors: high blood pressure, tobacco use, diabetes, atrial fibrillation and other heart diseases, high cholesterol, physical deconditioning, obesity. I mention these because these are risk factors that can be modified. Certain things can't be modified: your age, your family history. Race is a factor, as is your gender and history of prior strokes. But these things can all be dealt with, and if you work with your physician, you can do as much as you can do to prevent stroke. What does a stroke look like? Well, you hear about CAT scans and studies and all these things. Well, this is a CT scan. It's a specialized computer-generated image of your brain. Normally, the brain is a folded organ. You've seen pictures of that. And the brain here, you can see the folds that generally come with the normal side of the brain. The great thing about brains, for those of us who read images, is that the two sides should look the same. For those of you who are looking here, you can see quite clearly that that this side of the brain is very different from the other side of the brain. The fluid-filled spaces that we see on this side are almost disappeared here, and all of the folds here are no longer seen in this darker area. This is all indicative of swelling in the brain, and that comes with the damage that comes from lack of blood flow. One of the interesting things about the brain is that unlike many other areas of the body, the nerves of the brain don't store any energy. So as soon as you cut off blood flow to the brain, the clock starts ticking, brain cells start dying. So you'll hear us talk about stroke and you'll hear us talk about time. And the reason that time is so important is that while you can survive and actually recover from some damage to the nerve cells, that damage, that time for which you can act and from which you can recover is finite. So once we know that a stroke is in progress, everyone moves quickly and rushes as fast as they can to see if we can reverse the effects. We do specialized studies here at our stroke center. This is an MRI scan. You've heard of MRI scans of the brain. We use color maps to determine where strokes are, what nerves might be affected, and what treatments we may be able to offer. I wanted to take a couple minutes, since everything this year seems to be colored a bit by the pandemic, to talk about COVID and stroke for those of you who may be interested. Early on in the pandemic, we were a little baffled because we were not seeing as many stroke patients come to our stroke center as we had before the pandemic started. We also talked to a number of other centers, and they were experiencing the same thing. Conversely, a few places, New York City in particular, Philadelphia and other large cities who were experiencing large numbers of COVID-19 patients, were actually seeing an overall decrease in patients showing up with stroke, but an increase in young people having stroke and people who otherwise didn't have high risk factors. These things were a bit confounding and have led to a number of studies trying to decide, is there a connection between COVID and stroke? And if there is a connection between COVID and stroke, what is it exactly? It appears that the COVID-19 virus, or as some people are now calling it, acute respiratory syndrome coronavirus 2, or SARS-CoV-2, may be more likely to cause thrombosis, meaning clots, and vascular events, including strokes and heart attacks and pulmonary emboli, clots in the lungs and clots in the veins, than other coronaviruses and seasonal infectious diseases. Interestingly, the flu and other viral infections also increase the risk of thrombotic events and strokes, but not to such a great extent that we make a large deal out of it. But recent reports with the pandemic and COVID-19 have suggested a 7 or 8-fold increase in the odds of stroke in someone who has COVID-19 as compared with someone who just gets the flu. In our world, that kind of increase is a significant red flag and makes us all take notice about the vascular health of anyone who develops a COVID-19 infection. Now, stroke is not the most common thing or the main problem that patients who present to hospitals with COVID-19 have to deal with. And as physicians, we look at many other things, respiratory problems and breathing being the most common. But the patients testing positive for COVID-19 have an incidence of stroke of 1 to 6%. So that's, it's not one in 10, but a significant number of patients with COVID-19 will have either a small or a large stroke. As I said, in New York City, during the height of the pandemic, several centers were reporting large numbers of young people who had no other risk factors showing up with COVID-19 positivity and strokes. Laboratory findings in that study suggested that they were what we call hypercoagulable. There are factors in the blood that we can measure and that show that patients are more likely to form clots than they are in their normal state. The mechanism of this seems to be either systemic inflammation, and inflammation, as you know, causes so many problems, but one of the things it does cause is it causes the body to be much more heightened and much more likely to cause clots. Direct viral induced endotheliitis. The endothelium is a very specialized lining of the cells, of the vessels that keeps blood flowing and keeps clots from forming. The virus appears to attack the endothelium directly in some studies, and they think that this may be one of the reasons that it seems to have so much more of an effect and so much more of a potential to cause strokes and heart attacks and clots in veins than other viruses that have similar construction. But more important for me, and I think a more important message to most of you tonight, is that it's not so important whether or not COVID-19 causes more strokes, but it's most important that we recognize the symptoms of stroke and other medical emergencies and recognize that, usual things continue to occur in our daily life. People have heart attacks, people have strokes, people get clots in their legs from things other than COVID-19, and those things need attention. We need to remember to take care of ourselves the way we always have, and to recognize that other medical problems and situations can occur and can be just as devastating as COVID-19. In particular, in my world, it's important to recognize that if someone needs medical attention, we need not to be afraid of hospitals and medical centers, regardless of the current pandemic. Yes, the truth is, yes, there are large concentrations of people with COVID in hospitals, but the truth is that with all the precautions that are being taken at medical centers during the pandemic, they may actually be the safest place that you can hang out. Universal precautions, meaning the fact that we all recognize that body fluids, aerosolization, breathing on people, touching the surfaces that may have been touched by people that have infections are things that we think about all the time when we take care of patients here. Things are cleaned incessantly, and everyone recognizes and practices the most safe way to do anything that we do in looking at our patients. All the personnel are trained in how to work with people and how to contain viruses anything that anyone could contract or pass along. So coming to the hospital shouldn't be something that you avoid because of the coronavirus. In fact, we know that the earlier the coronavirus is addressed, the same as with most other medical problems, the better the outcomes will be. So in the context of all that, you might ask, is there anything that I can do to reduce the terrible effects of acute stroke, whether it be from COVID-19 or not? And the answer is a resounding yes. The most important thing in stroke care is recognizing stroke and calling the alarm and getting help as soon as possible. There's a very simple algorithm that we use to recognize stroke and for anyone that can easily remember and apply to someone who may be having a stroke. The first thing to recognize, I think, is that if you think somebody's having a stroke, they may well be having a stroke. Strokes happen all the time. It's not the most unusual thing. So what kinds of things do we see in people who are having strokes? Well, there's an acronym called BFAST or FAST. People who are having strokes have very significant symptoms. It's something that most of us can recognize immediately. People will stand up and suddenly they won't have any balance. They'll have to grab for a chair or they'll sit down. Yes, this happens occasionally, but not so dramatically. And if someone is having a symptom like that, it could be a sign of stroke. If they're having trouble with vision, people will tell you that suddenly they lose part of their vision in one eye, or their vision is doubled and crossed and blurred, and they really can't focus on what they're doing. If you look at someone's face, faces are symmetric. You know, my right side of my face looks like the left side of my face. But the truth is, if I'm having a stroke, the two sides of my face may look dramatically different. If I go to smile, one side of my face may not rise up. If I go to close my eyes, one side of my face the eyes may not move, the eyes may not close. This isn't normal. And if it isn't something that passes in 2 seconds, it may well be a stroke. Arms, you know, even people who are old and frail can put both their arms straight out, and they should hang and be in the same place. They should be able to raise them over their head, whether or not they have anything in them. If someone can't move one arm, or if someone tells you, or if someone reaches for their cup and it drops out of their hand, or they can't pick it up, that's not normal, and that could be a sign of stroke. Speech. Yes, every now and then we'll forget a word or garble something we want to say, and we quickly fix it. And as we get older, that happens maybe a little more often. But the truth is, most of us speak quite clearly, even into advanced age. If people are having trouble saying things to you, or if what they're saying doesn't make any sense, these people could be having a stroke. So why are all these things important? And, you know, especially if it's somebody you don't know, the last thing you want to do is start calling the alarm and looking like a fool. Well, the truth is, the first thing you want to do is start calling the alarm, because even if you're not sure it's a stroke, there are people who can tell you quite quickly that it is. And the last thing of this acronym is time, because as I said, once a stroke is started, the clock is ticking. So it's very easy for me to see someone in the emergency room, or to talk to, or to have an EMT person come to someone who you may think may be having a stroke and say, you know what, I think we're okay, it's not a stroke. We do that all the time, and nobody minds doing that. The concern that I have is if someone is hesitant to say, geez, this could be a stroke, that we may not find out that someone is having a stroke in time to make a big difference and to help them. So if someone is having a stroke, if it's an acute stroke, what's the end game? Well, the idea is to get patients to a facility that can treat the stroke in the time frame in which we begin therapy. And those time frames are different. We can give medicines right there in the emergency room within the first couple of hours that can dissolve clots and reverse strokes. We can actually go up and remove clots in a longer time frame and reverse the effects of strokes. These are things that have come up over the last 10 years. They're some of the more amazing things I've ever seen in medicine, and they can make a huge difference. And there are thousands of patients now treated in this country, and probably I would say hundreds, if not thousands, of people treated at this institution since I've come here 20 years ago that can attest to you that they are walking and talking because of timely stroke therapy. So what is a stroke center and why is it important? Well, stroke centers, like our center, are places in which a number of people from different disciplines have banded together and decided to attack the problem of stroke in a coordinated fashion. These are places then in which people are ready and standing by to treat acute strokes from all angles and to do it quickly. Mayo Clinic, Florida is a comprehensive stroke center. It's a national designation that we received in 2014, pardon me. We became the first comprehensive stroke center in the state of Florida, something we're very proud of. And that designation recognizes centers that can provide the most advanced treatments for stroke and lead in research and education dealing with strokes and cerebrovascular diseases. We do advanced studies such as this one. This is a CT scan measuring advanced blood flow. And in this study, you see the areas in the white boxes showing blood flow at 2 different times. What this shows is the blood flow here initially is delayed and later on becomes more normal. These are ways that we can tell that there are subtle blockages in the vessels and give us a reason for a patient's neurologic deficits. This is a CT angiogram, a study in which we can, again, quite quickly look at the vessels in a patient's brain. This is it looks like a lot of squiggly lines, but to those who read these studies, we can tell quite quickly that you can see, as remember I told you before, that one half of the brain should look like the other. Here on the right side, and CT scans the right is the left and the left is the right, but on the right side here, there's a normal vessel, which a carotid artery which ends and goes out to and delivers blood to the brain. You can see there's one here on the right and one and on the left that go up to the front. The one here on the left that should normally look like this is gone, and that's because it's acutely blocked. If this is discovered in time, we can take people to the Angiogram Suite. This is just like a cardiology laboratory in which we enter vessels in the leg or in the arm with small catheters, small tubes about the size of a piece of spaghetti, using X-rays to guide us. And you can see the monitors here. We can actually put these small tubes up into the neck and up into the brain and remove clots. This is a picture of a blood flow to the brain with a cerebral arteriogram. Now, normally, this should look like a goalpost with a very large vessel that comes out here and provides blood to this part of the brain. In this particular patient, there's a clot here which is blocking all of this blood flow. We use small retrievers, such as this is called a Stent Retriever. It looks like a piece of chain link fence rolled up like a Tootsie Roll. This is 3 or 4 millimeters across. They're about 25 millimeters in an inch, and it's maybe 15 or 20 millimeters long. This is a picture in which we have taken one of those small tubes and we put the retriever out into the vessel. Here's some of the clot which we've removed. Sometimes we put small tubes like this and just suck the clot out directly. This is a clot that we were able to suction out from the vessels of the brain. And we can take a situation like this in which a patient is unable to talk, unable to move their right side, restore the blood flow, and on that half of the brain. This is one where we've restored the blood flow on the right side of the brain and restore patient's function. So my message tonight is, yes, there's a pandemic, and yes, COVID is a problem. Scientifically, it looks like that COVID is a little bit more likely to cause strokes, but strokes from other causes still happen. Stroke is something that can be treated if it's recognized in time. So we hope that you'll take a moment to think about stroke in general, think about taking care of yourself in this time of pandemic, and make sure that you do the things that you need to do to stay safe and to stay healthy. But if you think that you or someone around you is having a stroke, please remember the things that we told you about recognizing things, not being shy about suspecting that someone is having a problem and getting help. We appreciate you taking the time here to be with us this evening. I will yield to the other speakers who will give us a little bit of insight to some of the cutting edge research being done here at the clinic for stroke and cerebrovascular diseases. Thank you.
Thank you so much, Dr. Miller. We now will have Dr. William Freeman, or Dave as we call him, be our next speaker. I'm sure you'll very much enjoy his talk. Thank you.
Thank you, Grace, and everyone. And it's a hard act to follow Dr. Miller and Dr. Talk and Grace. I guess now that we're all spaced out in accordance with CDC guidelines, I can pull this off during my brief talk. So my name is David Freeman, and I think these are tough times that we live, but I wanted to briefly talk on one of the stroke subtypes called intracerebral hemorrhage. And in particular, I think what you could see with Miss Lisa and Grace putting together is Mayo is the largest, oldest integrated non-for-profit healthcare system in the world. And the core mission is the needs of the patient come first. And I think the theme of tonight is that the system rallies around our patients. So I wanted to give you a glimpse of some of the work that we've done here and a lot of people behind the scenes. And I'm grateful to my colleagues showing our team really putting the needs of the patient first. So really, I want to talk about a systems approach to intracerebral hemorrhage. And these are the touch point kind of topics. So why should we care about intracerebral hemorrhage? Just to give you some fast facts, stroke happens about 760,000 patients a year. Intracerebral hemorrhage is the second most common type after ischemic stroke. So what Dr. Miller talked about earlier was ischemic stroke. A stroke happens about every 40 seconds. The term stroke actually is ancient, and it comes from the Greek word as if Zeus struck you down. 1 minute you're fine, 1 minute you're affected, and that really resonates, I think, with me. I'm always humbled by the time I take care of a stroke patient. And ICH is, I think we should all care about it because I think it has been one of those diseases that is really needs a paradigm change in therapeutics. And we've seen a real upheaval in the revolution for large vessel ischemic stroke in the last 5 years. Second, I'm going to touch on some things that we've done to re-engineer stroke care for our patients. Third, I'm going to touch on our mesenchymal stem cell research with Dr. Abba Zubair and James Meskia. And then lastly, touch on some minimally invasive approaches that Dr. Talk and Dr. Chichana have pioneered here that we're really seeing, along with some meta-analyses, some radically improved outcomes compared to historical control. And I'll touch on some future. So this is the type of stroke that I think needs more recognition by scientists, physicians, and everyone across the globe. If I didn't mention this earlier, last month, October 28th was World Stroke Day. And why is stroke important? Because stroke historically has been the second leading cause of death worldwide. Second leading cause of death worldwide. So we must remember that it's happening despite the COVID pandemic, and there are patients we don't want to delay to come in. But on the left image, what you see, these are the types of intracerebral hemorrhage that occur, the most common locations being the basal ganglia, the pons, cerebellum at the back of the brain, and then the lobes of the brain. And each one of these, by affecting the neuronal tissue, create neurologic symptoms. On the right-hand image, you can see that the hemorrhage can also create a shift of brain tissue that can push and affect the nutrient vessels and the cerebral blood flow to the surrounding brain tissue. So we call herniation. So all of these things we attack scientifically and medically and surgically to help a patient get better. The image on the far left is different than what Dr. Miller showed. That white image is on the CAT scan. That is a hemorrhage. And that cartoon in the middle just shows you how that and it can leak into the cavity in the brain. And this movie in the upper right just shows you one of these small vessels leaks into the brain. And as Dr. Miller alluded to, the hypertension or high blood pressure is one of the most common causes of hypertension, and it's preventable. And as Benjamin Franklin once said, an ounce of prevention is worth a pound of cure. So the public message being, let's make sure the blood pressure is being checked and treated despite what's going on in the rest of the world. And this is a snapshot of the mortality, and which is sobering. You can see only 12% of patients have a good outcome. The most estimates show the mortality is falling to around 30%. That's still quite impressive for any disease. And you can see that more than half of patients are left with persistent disability. So we have to do better with this. And there's no FDA-approved drug, not a single drug FDA-approved for this disease, which for me, from a research and clinician scientist standpoint, is one we hope to change. Now, I want to share with you a little bit of math. I love mathematics. It transcends and crosses over in multiple disciplines. And also, I think really when Dr. Jeff Saver came up with the time is brain mantra, mathematically, that paper resonates so well because you put a number to it. And in large vessel occlusion stroke, 1.9 million neurons are lost every single minute. So I want to share with you some math that we put in a paper in Mayo Proceedings that's coming out for intracerebral hemorrhage, which I think is even more astonishing. So the human brain weighs about 3 grams, and the average neuronal density is about 6.7 times 10 to the 7 neurons. And the average hematoma volume is about 33 cc, so that's about the size of a ping pong ball. And that equates to about 2.2 billion neurons lost in this disease. Now, if you do the Saver math and try to divide that up by minutes, that's 24 million neurons per minute. That is a factor of 12 higher than large vessel occlusion stroke. This, I would say, is a huge emergency, and there are at least 30 to 50,000 patients each year that have this type of stroke. So this is a call to arms. This is also from the World Health Organization looking at stroke and cerebrovascular disease burden. It's the #1 disabling human disorder known. This graphic just shows you on the bottom the age demographic as you get older. This big purple wave is cerebrovascular diseases, and that's the disability adjusted life years or daily. You can see stroke accounts for a large part of it, and death as well. So coming back to this Mayo event, I think one of our founders, Dr. William J. Mayo, said the best interest of the patient is the only interest to be considered. And in order that sick have the benefit of advancing knowledge, a union of forces is needed. And he said this very prescient in 1910. And what does this mean in today's time? It means that we all rally together. We all have our subspecialties, but when someone surrounds a patient, there's great things happen. And the other approach is that outlined by the national academies. And this is a systems engineering approach. So I think the theme of tonight is you can see behind the scenes how the Mayo system works. I think I've always applied a convergence or a systems engineering approach to patient care. And this, by the national academies, means you want something to be safe, effective, efficient, personalized, timely, and equitable. So how would this apply to stroke, and in particular ICH? On the far left, patients who have a stroke outside the hospital occur in what we call the pre-hospital phase. It requires early recognition, what Dr. Miller talked about, be fast. You have to jump on it quick. And I just shared with you the mathematics behind this. There are 24 million neurons per minute in ICH disease. The problem that we face is because there's not an FDA-approved drug, because there's not a surgical option approved, there's a sort of a therapeutic nihilism, and these patients, I feel, don't get the respect that they need compared to large vessel stroke, but I think that should change. In the middle part, you can see in the hospital in the OR phase, I think we'll need to revamp these terms called door to IR, door to EVD, similar to that we have for door to needle, door to IR. And when we do that, we'll be in a better place with rehab and preventative strategies. So this is just a slide where we've taken this engineering approach to patient care. And the concept was in the upper part of the screen is a stroke patient would have a stroke, and on arrival it was like a NASCAR scene. They'd have a lot of people around them who were trying to get an NIH, laboratory values, and a CT all at once. What we did in 5 years ago is we partnered with Apple and put iPads in a secure platform, and we beamed into the moving ambulance and measured the NIH before the patient arrived, about 15 minutes. This sent ripple effects through the American Telemed Association, and other hospitals adopted this model. And guess what? It's also cheaper than a mobile stroke unit, which costs about $1.5 million. This is simply like a secure FaceTime. The cool thing about this was the patients that could talk to us said, "That was amazing. I saw a doctor talking to me while I was pulling up to the Mayo ambulance." And guess what? We worked with the Harvard Business School and some other things. We realized that we could have the cath team ready as well as anesthesia as you need by the time that you arrived. So this was incredibly cool, precision medicine, and one simple intervention. A lot of people to thank from left to right. You can see in 2015, our chair of connected care, Dr. Turkanda, Wendy Hattery, Dr. Barrett, and Mauricio. And then 2 years ago, we incorporated this in simulation with our neurology trainees, and we made this a partnership with the community of Jacksonville with the ambulance services with our chair. And then this past year, we employed this in our neuroresident training using telemedicine. This is just a picture, obviously in pre-COVID times, just showing that partnership with Century Ambulance on the right and St. John's on the left. Really, this is all focused on the patient. And this just shows you Mayo now has its own ambulance service with 2 of these telemed units on board. And if you travel from one hospital to the next to come here, you will get this same world-class healthcare. These are just papers, the one from 2015 on the left and then the one on the right, how we realized that we were the first center actually to train residents in telemedicine. The future skills of the now future seemed very non-obvious prior to COVID. Now it's crystallized that this is definitely what we should be doing. The other cool thing is one of my fellows actually beams into the alcove where our stroke patient is from the neuro ICU on her phone using an InTouch secure platform. So these are the kind of the final slides here. What I'd propose, I mentioned earlier, is I think we need a redesign for ICH patients. We saw this major change, systems change with large vessel ischemic stroke with the perfusion imaging, the trials MR Clean, Swift Prime that happened in 2015. There was really a landslide of studies. And so I think we need to transform the door to needle into door to something. We need a therapeutic. Similar to TPA change was a game changer. And in terms of procedures, door to IR, door to the cath lab, these are door to IR times. We know from the CLEAR trial data with Dr. Dan Hanley at Hopkins, in the CLEAR 3 trial, the sooner you got an EVD, the better your outcome. And this is data that's probably not as widely known, but the sooner you got the EVD compared to 48 to 72 hours later, you had better cerebral perfusion and better outcomes. So simple placement of EVD if you have IVH or intraventricular hemorrhage from your intracerebral hemorrhage and hydrocephalus can be life-saving and change your outcome. And also door to OR. And this just going to touch on the impact of these trials that used to exist with open craniotomy compared to minimally invasive surgery. I think hopefully by the time I go through these slides, you'll see that there has been a change. These are all the ICH trials, MISTY, Stitch 2, Enrich is still ongoing, and we're eagerly to find out the results of that. On the far left, you can see clear, attached blood pressure as a covariate. Unless you have a spot sign, didn't make a difference. The problem with Stitch and MISTY is that perhaps these were technologies that were 15 years old. So Stitch was a mixture of open craniotomy and minimally invasive techniques. MISTY was putting a catheter and injecting TPA to dissolve the blood clot. This is a technology Dr. Talk has used, and I'm going to share with you a case that really surprised us. On the far right, what you can see is the pre and post-op CAT scan and the view that Dr. Talk would have that aspirates this clot out of the brain using a tubular type device. So he goes through really a small hole to extract that clot minimally invasively. And this just makes sense, right? Nowadays, when people get their gallbladder removed, they go through little chopstick type devices, and we're seeing this change. This is another device by a company called Nico and BrainPath, and you can see the pre and post-op images. And on the far right, you can see this tubular-like device that splays the white matter no more than 2 centimeters, so that when it's removed, those axons and neurons are not damaged. The amazing technology is that this can be combined with called diffusion tensor imaging and tractography, and there are corridors that you can get into the brain without damaging very eloquent parts and circuits in the brain. So this is really changing things. This is just an example image. And this is a meta-analysis that came out by Scott Gyanakti, just showing that there's a benefit for minimally invasive surgical approach compared to other treatments. And I'm just going to finish with some things on the horizon. Yes, I'm a space fan here near the Cape Canaveral. My daughter made me put this picture of this cute salamander called the axolotl, but they can regenerate any part of their body, including the brain. So there's a lot of research in regeneration on this. Mesenchymal stem cells we've researched. If you Google Dr. Abba Zubair and stem cells on YouTube, you'll find this video. It's a very touching video about his passion and what led him to this research in ICH. But I didn't get up here to sort of tell you that stem cells are the cure for everything. They're not. I wouldn't recommend them outside of a randomized trial. And on the far left, you can see a New York Times article on that, and also a New England Journal on that. This slide just shows you 6 years of research in one slide, the preclinical in vitro data, and leading to FDA approval. And I'm proud to announce that we just closed our first in human phase 1 trial, and 9 patients. So we just completed that, and now looking on to phase 2. And this just shows you there had the intracerebral hemorrhage patients we just studied had to be an ICH score between 2 and 4. And there were 3 dose groups. You can see the dosages of mesenchymal stem cells. And now we're hopeful to apply for a phase 2. This is that case I wanted to share with you that one of our fellows, Dr. Zara, and colleagues showed. And this is was a 36-year-old female. You can see has a right basal ganglia hemorrhage with intraventricular extension. She had a stroke scale, I think, around 35 when she came, which is very high, and her Glasgow Coma scale was less than 8. She was intubated. And this just shows you she had a ventricular drain placed for cerebral perfusion. She got into our trial. Dr. Tak used this minimally invasive catheter-based approach. Her Glasgow Coma scale improved. She had her EVD removed. And you can see her NIH stroke scale went from like 35 to about 5, and her modified Rankin, I think, was 2 the last time she was seen. And this is the pre-op versus post-op pictures. Just amazing improvement using the device. I'm not going to really talk about, we have studied intraventricular administration of stem cells, and we think they may work if they're closer to the site of bleeding, and that's stay tuned, more research to be done. So my last slide is really the future. Where do we go from here? I think we need earlier recognition. If any of you use CT advanced systems, there are machine learning algorithms that will compute the volume detection of a hematoma, which we know is tied with outcomes. I think in the future we will have decision support from these things to suggest mannitol, to suggest neurosurgical consultation, to speed the pipeline to better outcomes. If you're on warfarin or blood thinner, we have antidotes for those now, and including the newer ones. The third point is that I believe we'll need to have the ENRICH trial hopefully finish and see this change. We saw this with the IMS-3 trial prior to 2015, and I think industry really took off from there and led the science. I really hope that helps the patients. Next to last point is I don't know what the new therapeutic is, but I think we need something that helps reduce the neuroinflammation from ICH patients. They get neurogenic fever, and it's a very tough problem in the neuro ICU. And then last, I think you need this continuum of care, the team of people to really help survive this. At Mayo, we have 3 shields. So, we provide world-class healthcare, but we also teach the future generations. So this is a course we're going to live stream to the world that we used to do out of Orlando, but now we're going to do this live stream in May next year on the left. And then next year, we hope to see everyone live at our course focused on stroke and cerebrovascular disease in September next year. I just have to think it takes a village to have great outcomes. There's many, many people that are behind this work, and I thank them immensely. And most importantly, I thank our patients. I think, as Grace said, our reward is seeing the great outcomes. If we're staying up, working tirelessly in the middle of the night, it's all about seeing the patient return back to home with their family. So with that, thank you for your time.
Thank you so much, Dr. Freeman. Dr. Freeman actually sent up some cells with our space program, so he's very modest about what he does, but you'll have to ask him more about that. So coming up now, we just have a few minutes. We're going to listen again to Dr. DiBiase play some beautiful music for a few minutes. During this time, if you can send in some more questions for us, we do have questions, and we'll cover those in just a few minutes. Thank you. Beautiful. Beautiful. Thank you so much. We can't wait for you all to hear that live next time you're at Mayo. So we have some good questions that I'd like to cover. This is from an anonymous attendee. The attendee says, I have ACTA2 and very weak vessels. I need a stent in an artery in my brain. Is that safe for me?
Let's make sure we understand the question correctly. So
Yes.
I have a CTA and what?
The question is ACTA2. Does that question make sense? ACTA? Or how about this? Let's phrase it this way. The person perhaps has very weak vessels. What comes into play when you are trying to decide if that patient maybe has an aneurysm or stenosis and may need a stent in their artery? How do you weigh
And
that?
to make sure we address the question, the last
Sure.
portion, it says, is it that safe for me?
Yes.
To
Would
have
it
a
be
stent?
would it be if the person might need a stent but has what appears certainly to be weak vessels?
Good. So I'm gonna answer the question that is stent safe in people who have, some high risk for weak vessels. So we have many patients with engineered by nature based on our DNA that they have weak vessels. Many disorders are noted for weak vessels, Downless syndrome. Many underlying pathology, aneurysms are associated with our collagen, the way we're engineered. You compare it to tissue. If you have a thread that makes a jeans, the jeans is very stiff, or if you have a silk, very fine structure. Our vessels are the same. So some people have a dissection because they tear their neck, they have chiropractor manipulation, a car accident, and that's a weak vessel. That's why it tears. Now, the stent is needed for some of those patients when you have a dissection that causes blood to shut down. You restore the blood flow by putting a stent inside that helps the vessel to open up. You restore the blood flow and you prevent clotting inside the stent with blood thinners, and you give time for your body to heal over the stent. Very similar to an incision. We put the sutures for the body to heal on the sutures, and then it's a temporary cast for a broken arm. Very similar. Is it safe to do the stent? Well, yes and no, basically. The way I look at any procedure, the risks have to be much less than the benefits. We look at a procedure, what is the benefit? The first question, what is the patient gaining? What does it take to get there? What is the vessel? In general, brain vessels are much more fragile than other vessels anywhere in the body. Brain vessels swim in spinal fluid. They are aquatic vessels. They're very thin and they're much more fragile. So putting a stent in a brain vessel is very delicate in general. Outside the brain and the carotid is much thick walls like we showed today in the case. So this stent should be done for a good reason. Is it safe? I mean, sure, there is some risk, but definitely I would not go for a marginally indicated procedure, and it's a fine balance where the benefits have to outweigh the risk.
And Robbie, could you mention perhaps your Thursday case conference where you have a team of multiple specialists that can all weigh in from a different vantage point, being vascular neurology, vascular surgery, geneticists?
Absolutely. Like any system, like anything in life, you have to have a balance in your decision. And Dave, you're mentioning the vascular conference that we have where many people out of many disciplines, we outbid a management plan. That means everybody says, this is what I can offer to the table to these patients. These are the benefits and this is the risk. And that's how a team approach. That way, it's a very balanced decision because as a surgeon, I see one side of the cube. I mean, I know how to do procedure as safe as it can be possibly, but if my colleague neurologist have something better to offer for the patient, we let it go. We let the patient benefit from whatever is management. And often, sometimes it's a combined thing, basically, because with a stent, sometimes you fix the problem, but what about the next vessel? What about the other vessel? What about what's going to happen next year, the following year, and so forth?
Mhm. Thank you.
So I hope we answered the question.
Yes, yes. This is a question from Marwa. Can a stroke have some GI symptoms? In other words, she's asking, he or she, excuse me, is asking, can these symptoms be a clue to find out if they might have an aneurysm?
That's a great question. I think the short answer is it depends on what part of the brain it could affect. For example, if you have an intracerebral or intraventricular hemorrhage, there's a nausea center in the brain near the fourth ventricle, we call the area postrema. So that could present as nausea, which could be mistaken as a gastrointestinal symptom, just as one example.
Yes, certainly cause the nausea for sure, and a ruptured aneurysm. Yeah.
Yes.
It's a question from Frida. In the case of COVID-19 positive patient and they get a stroke and pass on, what is the proper way to say that maybe the patient passed on? Could it have been through COVID-19 or stroke? That's kind of a hard question.
So very good question. This
Yeah.
is what I call it the chicken and the egg analogy. So what we know so far, and we have, I mean, I compare pandemic today compared to April, and one of the nurses said initially it was much stressful. Now, you know, we're humans, we adapt to things. But here's the story about stroke and COVID. We know that this virus does cause blood clotting. So patients with COVID are higher risk of having stroke. At the same time, you know, if you have a stroke, you know, you need the treatment. So, but is stroke any risk factor for anything else? You know, no. The COVID risk factors basically is related to, I mean, this 6 feet, social distancing is the key. Putting the mask, and that's how we're preventing this COVID from spreading from one person to another person. Many people with COVID come with a stroke, basically. What I fear as a specialist is many people are missing the window to intervene, to open the vessel, restore blood flow, so their stroke doesn't cause as much damage on their brain. And, you know, from my perspective, the message I want to spread to patients, yes, it is fear of COVID, but if it's a stroke, give us a call and call 911. You know, there is specialists everywhere who are, you know, able to handle this. And we hope that this pandemic does not overwhelm the healthcare system. And that's why we're doing all the social distancing to slow it down. I mean, ultimately, you ask yourself 10 years from now, if I look back, how is this and how did we handle it? And you do not want to overwhelm the healthcare system. You don't want, you know, healthcare system to not to be able to care for every patient and give them the best chance. And if you look at casualties and mass events, you know, Boston Marathon bombing events, you know, all these big events where the healthcare system got overwhelmed. I mean, you don't, you know, you want to do things appropriately and don't reach a stage of to triage patients where, you know, you're doing things that are not, you know, the best for every patient. I'm not sure if I answered the question basically, but, you know, was that clear?
Yes, sir.
Okay.
I think
Thank
so.
you.
Yeah. We have probably just, gosh, we're already running out of time already. We could take all night. What percentage of people have aneurysms, and how, what percentage of those people have a risk for rupture?
Good question. Across the table, if you 3 to 5% cross incidence. That incidence goes up if you have a family history of aneurysm, somebody with a family history, first degree relative. The numbers to remember 7 to 8. So that risk goes from 3 to 5 general population, you know, 7 to 8 with a family history. Now, as we get older and we age, when we get over 30, when we smoke, when we have high blood pressure, that risk keeps mounting up higher and higher, and it reaches up to the 30%. People with other disorders, polycystic kidney disease, any other disorder that put us at higher risk of having weak blood vessels have more aneurysm. People with abdominal aortic aneurysm have more associated. Sex, gender difference, you know, women are higher risk because their tissue is engineered, you know, in such a way that they're higher risk. Hormone related, who knows, but definitely women. people with a family history as well. You know, so let's say a member has a family history. Let's say a mother has an aneurysm. Okay, now her sister, that mother's, you know, so the aunts for the children have higher risk than her children because the sister carries the same genes from both parents. The children or siblings carry half of the genes from their mom. So those are the people who are the highest risk, and that goes across the numbers.
Certainly. What would you all say is the most difficult part of your job? What's the hardest part of your job working in healthcare today?
Dave, go ahead.
I think the theme that we've been talking about is if you have stroke, get access quickly. I think one of the hardest thing is someone who they kind of hope that their symptoms would go away and they wanted to sleep it off and they come in the next day and they're outside of any kind of therapeutic window. That's very hard to explain to the patient and the family just where the therapeutics are right now. We're constrained by the technology in our time. So that's kind of a painful thing. And that, again, underscores why be fast, act fast, get to the hospital so we can evaluate it and treat it quickly.
Certainly.
Well, everybody has hard is defined different. For me, what's the hardest part is basically seeing patients not doing well. It just takes on toll on me, basically. I take every patient problem, you know, in my mind, just affecting my brain waves, how I think. You know, if I see a patient, you know, with a bad outcome, or, you know, I just think about it. Sometimes I dream of my patients, and you see as a doctor how things affect you. But, you know, I take my specialty at heart, basically. I like what I do very much. And, you know, Dr. DeBakey had a statement, you know, I quoted my daughter the other day about medicine. He says, I love what I do. I love it so much to the point where I don't want to do anything else. You know, well, I want to do something else. I want to be with my family as well and my kids. And because I'm, you know, you committed to a family and you have to give them their time. So juggling life with what's going on, being busy, accepting. So it's an art to really be a good doctor, taking good care of your patients and living in a balanced life with all what's going on. And that's the biggest challenge for me.
Yeah. Okay. Gosh, we have so many good questions. We probably just better take two more if we have time. Salam asks, can a stroke affect spelling and reading over a course of a year, or is this a sign of early onset dementia?
That's a great question. My short answer would be both.
Yes.
We've seen it both. We've seen people with dementia progress, variants that affect their speech, and also on the other side, the small blood vessels that affect their speech areas from what we call small vessel disease. Usually if it's a larger vessel, it happens more suddenly. But yeah, it could be either or both.
Yes. Maybe two more. We'll go for two more.
Sure.
We'll keep you a little bit later. Sorry about that. Or maybe it's good. We still have a lot of participants still in. Mimi asks, my brother had a subarachnoid hemorrhage. A coil and stent were placed to stop the bleeding, but his cerebral fluid would not drain properly, and therefore they placed a external drain. And I think probably what this person means actually is that they had a VP shunt. Any long-term side effects of placing a VP shunt or a shunt?
Most people with aneurysm require the shunting in the acute phase. If you look at those people 10 years from the date of implantation, most people restore their ability to absorb spinal fluid. So spinal fluid gets secreted and absorbed in a very balanced way. People with subarachnoid hemorrhage, they have impaired absorption of spinal fluid and buildup of fluid. So we put a temporary device to divert the flow, get to their abdominal cavity. The long-term effects, especially for subarachnoid patients compared to other people with shunt dependent, is much less because that shunt, you worry about it malfunctioning or not working well. But most of those patients over time restore their ability to absorb the fluid. So I wouldn't worry about it. I would consider it as, yes, he has a device in his body for a problem that he had, and let it go. Keep following with your doctors, and you know, if anything happens, be vigilant about it.
Okay, thank you.
But not a major concern, of course.
And last question, what is your favorite part of your job? What keeps you going every day and coming in and working so hard?
You know what? I would like to ask you this question because you have been here for 23 years and we can all share our answers. But you know what is the favorite part? I see the smile. I see how much you love what you do, and you kind of you are the heart of the patient beating in a hospital. What is the favorite part of your job?
Well, thank you. I do. I love my job. It's definitely a sense of trying to take care of the patient and their families, feeling that sense of relief that someone is helping to care for them and that making the right decisions for them. I love working with a team, which is absolutely critical. I love helping them feel better, for sure.
Dave, what about you?
Mhm.
You're so passionate, and I've not seen. I mean, you are in healthcare a top gun, given to medicine and given to Mayo. And you're a gem at this facility, and the way you work 24/7 on vacation, you know, is amazing. What is your drive to do all this?
Thank you, Robbie. You're very kind. I think back a memory that we have these growing memories of successful outcomes. So I remember when we moved into this hospital, April 12th, 2008, having to ride down with the patient in the ambulance, the patient that was super critical, that I think a lot of us weren't certain we're going to make it, and losing a lot of sleep, perhaps for a month, but seeing that patient return to her family, her two daughters, and her husband. And she knows who she is out there, but we have this growing family of wonderful outcomes, returning people to the community with their families. That's what it's all about.
You know, for me, I compare us doctors and healthcare providers basically as a link in a period of life where humans become very fragile. Okay, and there is a very fine line between life and a good outcome, or a change in your outcome, and your life will never be the same. We interact at a very critical part, and what we do does matter for patients. And for me, you know, I mean, I get this adrenaline rush every time I see a patient doing well. And the biggest reward is to see that what we did as a group, you know, we play roles differently, but if you look at any crew, you know, it's a crew. You cannot do anything without your partner and your team. And the biggest reward is when I see patients going back to their life and I see what we made has made a difference for them.
Well said. Well, thank you, everyone. Thank you, everyone at home. I also wanted to say a special thank you to Lisa Mooney, who's in our audience. She was our roving Zoom operator on the floor. And thank you to our tech team. And thank you to everyone gathered here today.
And Grace, can I share one last quote? I think that
Sure. Yes,
resonates
please.
in our times. When we look at our founders with more than 150 years ago, they made it through the 1918 pandemic. So about 8 years later, William J. Mayo said, "The ills of today should not cloud the horizons of tomorrow." And I think we will get through this, and we'll get through this together.
Absolutely.
That's
well
a
said.
great, you know, there's many people, again, this was our first, you know, Zoom in. And as we adopt this, I would like to recognize many, many, many people who are behind the scene to put this together. You know, Lisa, Claudia, you know, I'm not going to name people, but again, this is a team effort. And like an iceberg, big piece of this iceberg is under the water and people didn't see it. But to me, we have to adopt what's happening, and we have to look at a future, how to adjust and keep going. So thanks for everybody who helped, from fellows, from people who played music, from people who helped putting the website, team support, tech support, you know, and we would love for the patients to get back with us because we're starting to use this electronic way to communicate with patients, and it's hard in healthcare with HIPAA and all this stuff. So we would like to hear about it. And this is probably going to be a little bit more kind of an advertisement thing versus, so for people who had things, please let us know how, how we can make this better for patients.
Yes, we're new at this, so thank you for joining us and your patience.
Thank you, Dr. DiBiase, for your gracing us with your beautiful music, and Ricardo for helping behind the scenes, as always, making things happen. Thank you. Thank you all.
Great. Thanks, everyone.
Have a good evening.